All right, let's talk about cardiovascular physiology. So what do we have? We have a cardiac output variables, right? So the first cardiac output variable is stroke volume. What is stroke volume? Stroke volume is affected by contractility, three things: contractility, afterload, and preload. Stroke volume increases with increase in contractility, increase in preload, and decrease in afterload. But the question is, what is stroke volume? So for that we have to go to the next page. It's right here. Let's look at stroke volume. Stroke volume, it's basically whatever is going outside the volume of blood ejected from left ventricle with each beat. So with each beat, whatever goes out of the left ventricle, that's going to be the stroke volume. And how do we calculate that stroke volume? EDV minus ESV, and diastolic volume minus your end systolic volume would give us the stroke volume. And this is your absolute amount of fluid, amount of blood actually, that goes out with each beat into the left ventricle. And what is normal stroke volume? It's about 70 ml that goes out with each beat. Let's compare this with this second one, which is your ejection fraction. What is this? Well, this is relative volume of blood that is ejected from left ventricle with each beat. So see what's the difference? Is an absolute volume that goes out, relative. When we talk about relative ratios or all that, so they're going to come in percentage, right? So what is EF? EF has to be, the normal EF has to be greater or equal to 50%. That's your normal. So this is the stroke volume which goes out of the left ventricle with each beat. So let's look back here. So what is increasing that that blood pushing out of the left ventricle? So increase in contractility. It's simple. And where do we increase in contractility? Anxiety, exercise. When you have more contraction, more blood is going to go through your left ventricle outside into your aorta. Same thing goes with the preload. The more blood comes into the left ventricle, the more goes out. Increase in preload. Example, early pregnancy. Or decrease in afterload, meaning you don't have a lot of resistance in the aorta or other vessels, systemic vessels. So it's a lot easier to push that fluid out into the aorta and all the vessels, systemic vessels, because of decrease in afterload. Okay, so looking on the right side, what do we have? SV cap is a mnemonic. And SV cap basically says right here, stroke volume affected by contractility, afterload, preload. Okay, stroke work, SW, is work done by the ventricle to eject stroke volume. Almost the same thing, just it's now the work. So the work done by the ventricle to eject SV. So stroke work is directly proportional to your stroke volume times the mean arterial pressure, the MAP. Okay, a failing heart has a decrease in stroke volume, systolic and or diastolic dysfunction. So that's easy. I mean, a failing heart, I mean, if the heart is failing, I mean, left ventricle is failing, it won't be able to push that fluid out, the blood out of the left ventricle, right? So of course you're going to have a decrease in stroke volume. In systolic, either systolic and or diastolic dysfunction. So both will have decrease in stroke volume. Okay, so that's all about stroke volume. Let's look at your contractility. What is contractility now? So the contractility and stroke volume would increase with catecholamine stimulation via the beta 1 receptor. And what would they do? They would activate the protein kinase A, which will lead to phospholamban phosphorylation, and they would activate the calcium ATPase channel, which will cause increase in calcium storage in the sarcoplasmic reticulum. Second thing they would do is they would activate protein kinase A, would lead to calcium channel phosphorylation, increase calcium entry, increase in calcium-induced calcium release. So what are we trying to say here? So in a nutshell, in all of these factors, we're going to be increasing the calcium levels. Somehow, either we are stimulating the beta 1 receptor through catecholamines, or either we're just increasing the intracellular calcium, or we are trying to decrease the sodium calcium exchanger, so you would have increased calcium intracellularly, or we're giving digoxin, which would stop the sodium potassium pump, that would indirectly increase your uh, intracellular calcium. So all of this, in a nutshell, we are looking at an increase in calcium levels that would increase contractility. So when you increase contractility, you already know that's going to increase the stroke volume, right? On the left side, what do we have? So it's contractility and stroke volume would decrease with the opposite. So beta 1 blockade, decreased cyclic AMPs, heart failure with systolic dysfunction, acidosis, hypoxia, hypercapnia, decrease in oxygen, or increase in your carbon dioxide, or calcium channel blockers, non-dihydropyridine calcium channel blockers, right? So these are all the things which would decrease the calcium levels, causing decrease in contractility. And this acidosis is decrease in pH, and decrease in oxygen and increase in your bicarb would also do the same thing, cause acidosis, decrease in pH. Non-dihydropyridines, you're specific about these. They are the verapamil and diltiazem. Verapamil specifically works just on the heart, while diltiazem works on the heart as well as on the vessels. Okay, so this is all about your contractility. In a nutshell, calcium increase and calcium decrease. Now the next thing is about, let's erase this. Next thing is about the preload. Let's talk about preload. What is preload? Well, the preload is the amount of blood, again, the definition here is the amount of blood that would come in to the left ventricle. That's the preload. So preload is approximated by ventricular end diastolic volume, EDV. Depends upon venous tone and circulating blood volume. So you could, again, what are they trying to say here? That how would you know how much blood is coming into the left ventricle? Well, to calculate that, you could approximate the fluid by seeing how much is the end diastolic volume in the left ventricle. The other things they haven't mentioned here, but which is almost the same thing, is left ventricle end diastolic pressure, or again same thing, left ventricle and diastolic volume. Okay, so these are the things which would tell us how much preload is being within the heart, how much preload has come from the veins upward into the heart prior to the contraction, right? So we know venous vasodilators, for example, nitroglycerin, would decrease the preload. And why would they decrease the preload? Again, simple thing. When you dilate the veins, the less blood is going to go to the heart. When the less blood go to heart, less blood is going to go to left ventricle. So you would have decreased with the vasodilators, or you will decrease the preload. Okay, looking at the next one, what do we have? That's the afterload. Afterload is the free resting flow out of the left ventricle. Again, what is it? Is the forces resisting flow out of left ventricle. So the afterload is approximated by MAP, mean arterial pressure. So if you increase the wall tension per Laplace law, you will increase the pressure. When you increase the pressure, you're causing increase in afterload, right? So take it afterload like this. Okay, let me just do it here. So this is the preload from the veins coming to the heart, right? This is all the preload goes to the lungs, get back here, goes back. So the preload is going to be whatever is going into the systemic circulation. So if you have increase in wall tension, it will increase the pressure. You increase the pressure here, it's going to be hard for the left ventricle to push that fluid out, right? So that will increase the afterload, right? Because of increase in pressure. The next thing is arterial vasodilators, for example, hydrolysine. Hydrolysine will decrease the afterload. Again, same thing with you. They were constricted. The vessels were constricted. You open them up, vasodilate them. Guess what's going to happen? The heart has an easier way of getting things out, and that would decrease the afterload. ACE inhibitors, ARBs, decrease the preload and the afterload. Important thing. Chronic hypertension would increase the MAP, mean arterial pressure. That would cause left ventricular hypertrophy. Okay, so left ventricle compensates for increase in afterload by thickening hypertrophy in order to decrease wall stress. Again, if you have increase in afterload, let's increase in afterload, and the heart has a hard time pushing things out into the vessels, it's going to go into hypertrophy. That's exactly what they're trying to say. Left ventricle would compensate and go into hypertrophy. Even with chronic hypertension, what do you have? What's hypertension? You have increase in the afterload. So and increasing the mean arterial pressure, the pressure is increased, causing increase in afterload. The heart has to push harder to put the fluid into the aorta and all the other vessels. So it's going to go into hypertrophy. All right, the last one here is the cardiac oxygen demand. Cardiac oxygen demand. So myocardial O2 demand is increased by increase in contractility. The more the heart works, the more ATP it requires, the more oxygen it needs. Simple. Increase in afterload. The more the pressure is outside the heart, the more harder is it for it is going to be for the heart to push the fluid, the blood out of the left ventricle. So it would need more oxygen. Increase in heart rate, again, heart is beating faster, it needs more O2. Increase in diameter of the ventricle. So when you have increase in diameter of the ventricle, it's going to take all of that energy to push that fluid, increase amount of fluid outside from the left ventricle, causing increase O2 demand. So coronary sinus contain most deoxygenated blood in the body. We did talk about it in anatomy, I guess. So the next is where we have wall tension follows the Laplace law. Wall tension equals pressure times the radius. So wall stress, on the other hand, is the pressure times radius by 2 times the wall thickness. So that's the wall stress, wall tension, and the Laplace law. What else we can have? Okay, let's talk about one extra thing here. So all you know that, okay, we have aorta, and then aorta is a big artery, right? After that, we're going to go into arterioles, small arterioles. So arterioles at this point, which are like sort of a branching, right? These arterioles here, they have the highest resistance. Okay, and the veins, they are the highest, so it's gonna go into all of that and then make vein, right? So these veins are going to be, they will have highest compliance, meaning the distensibility. They would have greater amount of distensibility, highest compliance, and that's an important concept. The arterioles, they have highest resistance. Venules or veins would have highest compliance. These capillaries here, right? These capillaries, they are the largest surface. They are the largest surface in total cross-sectional area for nutrition exchange. Okay, so there they have the largest cross-sectional area, meaning they are the largest. For nutrition exchange, we need that. Okay, so this is what we have for this page. Moving on to the next one. It's about stroke volume again. We talked about it. Is the stroke volume equals the EDV and diastolic volume. Diastole basically means when the heart is relaxed and amount of fluid that can be filled, amount of blood that can be filled within the left ventricle is your diastole, minus the end systolic volume. So the systole is whatever is left over after the contraction, and whatever that is going to give you stroke volume. And normally the stroke volume is about 70 ml. Okay, so ejection fraction is EF, ejection fraction equals again the stroke volume divided by and diastolic volume. And stroke volume is EDV minus same thing from top, EDV minus ESV, and divided by EDV. EF is an index of ventricular contractility. Important thing. Decrease in systolic heart failure. It would decrease in systolic heart failure, and usually normal in diastolic heart failure. Okay, so EF normally you're looking at about greater than 50%. If that is decreased, you're thinking about systolic heart failure. What is systolic? That you can't contract. There are two things, like systolic versus diastolic. Systolic means you can't contract the heart, while diastolic is you can't relax the heart. So here the problem is contraction, of course, because you can't contract, you can't push the fluid out. You will be less than 50% of EF, ejection fraction. Moving to the next one is cardiac output. What do we have for the cardiac output? CO equals Q equals SV times HR. Okay, so SV again, stroke volumes times HR. So what is the Fick principle? Here what do we have is, let's say we can't measure the stroke volume or the heart rate somehow, so we can measure the cardiac output in a patient by just doing this Fick principle, which is rate of the oxygen consumption, oxygen consumption. And how can we measure this rate of oxygen consumption? We can measure this via checking the oxygen. We have something called O2 meter, oxygen meter. Okay, so we check the ratio of exhaled air and how much oxygen do we get out from the patient when he exhales or when he or she exhales. So that's the oxygen meter. By arterial O2 content minus venous O2 content. What is arterial O2 content? Well, arterial O2 content is the arterial blood. Normally you can take it out from this arterial blood or peripheral artery to check out arterial O2 content. Again, the name says right there, arterial O2 content means artery. Straight up take out the blood from artery, not the vein. Venous O2 content can be checked by pulmonary artery or AV difference in the oxygen content. Okay, so pulmonary artery, remember, has the venous blood, meaning remember the heart, right ventricle sends the blood into pulmonary artery, right? And this is all deoxygenated blood. Okay, so on the right side, which is sort of a more important thing, is in early stages of exercise, the cardiac output is maintained by increase in heart rate, increase in stroke volume. So in early, okay, let's look at the later one and then we compare. In later stages, the cardiac output is maintained by increase in heart rate only, because SV, which is stroke volume, plateaus. So just imagine that while you're just running in the early stages, two things are working to maintain this cardiac output. That is your heart rate is increasing, but on top of that, your stroke volume is increasing. Stroke volume is also increasing at that time because it has the capacity to push harder, and to a limit, then it's going to plateau because it is doing its max. So later on, the only heart rate would increase. Okay. So to remember this thing, just remember that when somebody's exercising, you don't think about stroke volume. What do you think about heart rate? You say, oh, the person is exercising. Of course, he gonna has a lot of uh, tachycardia. He's gonna be having increase in heart rate. So in later stages, you just have increase in heart rate, while in early stages you have increase in heart rate and increase in stroke volume. Okay. So next point is diastole is shortened with increase in heart rate, high yield point. Diastole, remember we talked about in anatomy. In diastole, why is it important? Because in diastole, let's say this is diastole and this is just contraction. In diastole, we are getting the blood to the heart itself, right? At this time, we're getting the blood to the heart itself, the myocardium, endocardium. Everybody's getting the blood supply at this time. But diastole would get shortened when you increase the heart rate. For example, in ventricular tachycardias. So now you have instead of normal period, let's say from here to here, now you just have this much period, and then you're just contracting this one period, then you're still contracting diastole, again contracting. So all you have is this period in which you're getting the O2 to your heart, right? So guess what? If you just imagine this, if you already have a coronary artery disease and you're exercising, exercise is good, right? For sure. Why not? You're exercising to your limits. Your diastole is getting shorter and shorter as your heart rate is going up, right? So as your heart rate is going up, your diastole is getting shorter and shorter. So you already have CAD, meaning you already have atherosclerosis there, and you need more oxygen. But at this time, when the heart is contracting a lot harder, a lot more than 100 times, and you have a low O2, you're gonna go into uh, uh, ischemia of that place, that heart, right, at that time. So that's very important, very high yield. That diastole is shortened with increase in heart rate, and leading to decrease in diastolic filling time, so decrease in stroke volume and decrease in cardiac output. Decrease in stroke volume and decrease in cardiac output. And patient who already have CAD, the best way to do is have a brisk walk. No need to push a lot that your heartbeat is about 160, 180. No, don't need to do that. That's why if you recall in the stress test, that's exactly what they do. Increase the heart rate to see where the pain is going to be. That's called stress testing, right? So, um, so yeah, that's a high yield point. Moving on with the pulse pressure. What is pulse pressure? So the pulse pressure, it's PP, pulse pressure, equals systolic blood pressure minus diastolic blood pressure. Two things, right? Pulse pressure is directly proportional to stroke volume and inversely proportional to arterial compliance. Increase in pulse pressure in aortic regurg. So where would we have increase in pulse pressure? In aortic regurg, aortic stiffening, isolated systolic hypertension in older adults, OSA, obstructive sleep apnea, increase in sympathetic tone, higher output state, for example, anemia, hyperthyroidism, exercise transient. Exercise is a transient increase in PP. While decrease in PP is an aortic stenosis, cardiogenic shock, cardiac tamponade, and advanced heart failure. Okay, so these are a couple of things, but remember this aorta is important. Aortic regurg versus aortic stenosis. Aortic regurg has increase in pulse pressure, while aortic stenosis has decrease in pulse pressure. And what is pulse pressure again? If in a schematic diagram, what do we have like a pulse pressure? Let's just draw it. So we have a systolic blood pressure, we have a diastolic blood pressure, and this thing right here is going to be the pulse pressure. Again, PP equals SPP minus your DBP, which is diastolic blood pressure, right? So that's what you have. And what is mean arterial pressure? Let's just draw it also here. Mean is just the mean of the arterial pressures. So MAP is there, which is again mentioned here. So let's talk about MAP. MAP equals cardiac output multiplied by TPR, which is total peripheral resistance, which again tells us about afterload. So a couple of names here. TPR is same thing as you have TPR, total peripheral resistance, which is going to be equal to your peripheral resistance, vascular peripheral resistance, or anything which talk about afterload. And when the terminologies come up, I'll definitely talk about that. So MAP at the resting heart rate is 2/3 of the BP, DPP plus 1/3 of the SPP. Why 2/3 DPP and why 1/3? Why not just add them together, right? Because the blood stays in diastolic blood pressure for a longer time. That's why it's 2/3 of the diastolic blood pressure and only 1/3 of the other one. Because the blood stays in more here. The blood stays more in your diastolic blood pressure. Systolic blood pressure is just whatever goes out. So let's actually talk about it here since we are talking about it. What is your systolic blood pressure, SBP? So systolic blood pressure is determined by your stroke volume. Right, so as you increase the stroke volume, meaning as you increase the amount the blood that goes out of the left ventricle, you increase the systolic blood pressure. What is diastolic blood pressure? Diastolic blood pressure is determined by your TPR, total peripheral resistance, or SVR, systemic vascular resistance. So as you increase your total peripheral resistance, which is again your afterload, as you increase your TPR, total peripheral resistance, you increase the diastolic blood pressure. So systolic blood pressure is determined by the stroke volume, while diastolic blood pressure is determined by TPR, total peripheral resistance. Mean arterial pressure depends upon your cardiac output, whatever is going out of the from the heart, which you can calculate by SVR. Again, let me just actually write this down here. Cardiac output, which is determined upon your SV, stroke volume, times the heart rate, and this whole thing multiplied by TPR would give you MAP, mean arterial pressure, which is again at resting heart 2/3 DPP and 1/3 SPP. DPP more because the blood stays within the diastole more and not in the systole, because systole is just whatever right away like goes out of the heart, while in diastole is all the circulatory system that it has to travel. Okay, so that's all for the mean arterial pressure and your pulse pressure. Moving on with this Starling curve. What do we have for this? Starling curve, very high yield. It talks about force of contraction is proportional to the end diastolic length of cardiac muscle fiber, which is the preload. So what are they trying to say? They're saying force of contraction is directly proportional to your end diastolic length of cardiac muscle fiber. Okay, and although they're just saying cardiac muscle fiber, but the thing that you know, but you should know, which is they're talking about sarcomere length. Sarcomere length. Muscle fibers are the sarcomere lengths. So other points to be mentioned here is when you increase in the preload, that increased preload stretches the myocardium, and increases the and again increases the end diastolic sarcomere length. End diastolic sarcomere length. In other words, increases the end diastolic muscle fiber length. But important thing is sarcomere length. Okay, and that would do what? Okay, guess what? We have increased preload. We have increased the end diastolic sarcomere length. Now what? So that would increase the stroke volume and increase the cardiac output by this Frank-Starling mechanism. So if you look here, the same thing. Let's just look at here. So you're at rest. Your stroke volume and the cardiac output right here is at this level. But as soon as you increase the preload a little bit by walking or a lot more by running, you have increased your stroke volume and increased in cardiac output. And that is due to the fact that as soon as you increase the preload, you're going to increase the length, the fiber length, the end diastolic fiber length or end diastolic sarcomere length of each cardiac muscle fibers, and the cardiac muscle would expand because you have increased the preload. So whatever comes here, it has to go out, right? So because you have increased the preload, which came here, now it has to go out, and that would increase the cardiac output and the stroke volume. I hope that makes sense. So by definition, Franklin Starling curves, Frank-Starling curves, right? They state that as the cardiac muscle increases, increasingly stretched, as the cardiac muscle is increasingly stretched, by that would the cardiac output would increase, the CO would increase. So again, so this was normal heart, let's say, as you increase the stretch on this cardiac muscle fiber, it's gonna push it out. Whatever it expands, gonna push it out to a limit. Now that's the a clue here. So it's not a balloon that you push it out, push it out, push it out. It's gonna be like bigger, getting bigger, and all of that. No, it's not gonna do that. There's a limit. So Frank-Starling curve tells us the same thing, that this is the normal, but you push it out, it's gonna push that all the fluid out, increasing the stroke volume, increasing the cardiac output, but to a limit. But to a limit. Why is that? Why is to a limit? Why shouldn't we have as the more fluid we put in, the more it's gonna go out? No, not necessarily. There is a limit, and if you look here, I'm gonna show you where's the limit. Here it is, but after this time, the curve plateaus, no matter how much preload is coming here. So, of course, you have increased the preload, but look, the curve plateaus. Why? And that is called length-tension relationship, due to length-tension relationship. And this is exactly what the Starling curve says, or Frank-Starling curve tells us, that the force of contraction is proportional to end diastolic volume in the cardiac fiber preload, which they haven't mentioned is there is a limit, and then it plateaus, and that limit is due to the fact that there's a length-tension relationship, meaning the sarcomere length would be giving its max. The sarcomere length is just giving its max at that time. After that, because you can't increase more the sarcomere length, you will not increase your cardiac output or your stroke volume, and it's just going to plateau no matter how much preload you increase after a point. I hope that makes sense. So now let's look at the factors affecting it. So increase in contractility with catecholamines, positive inotropes like dobutamine, milrinone, digoxin, decrease in contractility with loss of functional myocardium, for example, MI, beta blocker acutely, or non-dihydropyridine calcium channel blockers, or even in heart failure. So example, on the left side you have a pretty nice one. This is normal. It goes on towards the left with a normal exercise, and all of these factors play in. All of these increase in contractility, right? But if it would go down if you have a heart failure. Everything is going to go down. But with the heart failure, if you give positive inotropes like digoxin, even with the heart failure, you can pretty much save your stroke volume or cardiac output by giving digoxin, and we'll see that how digoxin uh, increases the cardiac output without increasing any heart rate or anything else, just due to the fact that it preserves the calcium or keeps the calcium within the cell, causing increasing contractility and increasing stroke volume and cardiac output. Okay, um, so that's what we have. Some extra thing we have is uh, they're saying just the increase in contractility, but the second thing that you have to know is this is not just one thing. It also depends upon the fact the second thing is about when you decrease the TPR. So two things, TPR and increase in contact. Either you increase contractility, either you decrease TPR. What is TPR again? I mean, this is a simple thing, but very high yield. So you have a right, left, right, right atrium, right ventricle, left atrium, left ventricle. So whatever is going out in the vessel, right, whatever the heart is trying to push out in the vessel, that's going to be your TPR, total peripheral resistance. Again, as the name suggests, total peripheral resistance, TPR. So either you increase the contractility of the heart, or either you decrease the TPR, you are going to have a curve which is going to go towards the left, which is that the cardiac output would increase. Normal is here, but it's going to increase. The cardiac output and stroke volume would increase. And how can you decrease TPR? Some of the things that you can decrease the TPR are why you're decreasing afterload, or vasodilators, not veno. Remember, venos are wane, and vasodilators are the whole thing, or even sepsis as a pathology. Decrease in contractility or increase in TPR. What is increase in TPR? By vasopressors can increase TPR, total peripheral resistance, and they would cause the curve to go on the right side and decrease the cardiac output and stroke volume. So just a summary of this, Frank Starling, all it's trying to say is the more fluid comes into the heart, the more it pushes out, but to a point. After that, there is no more pushing out, and it's just plateaus. And why? Because of a length tension relationship, due to the fact that each muscle fiber sarcomere length has its max. It is doing its max. It is at its max length, and it cannot increase its length more than this. That's all about Frank Starling, a very high yield point. Moving on with the next thing. What do we have? Okay, resistance, pressure, and flow. So volumetric flow rate, which is the Q, equals the flow velocity, V, times the cross-sectional area, A. Well, resistance equals change in pressure divided by the volumetric flow rate, Q, equals 8N, which is the viscosity, times the length, and very high yield is this, which is R4, right? R4 is very high yield. Pi to the radius R4. Okay, so what is the radius to the blood vessel to power 4? So here, what do we have is, it's basically, if you change a radius, so let's just talk about here, change in radius. If you change a radius, there's going to be a large change in resistance. Large change in resistance. Why? Because the power is to 4. So if you change a radius to a very minimal thing, it's going to change a lot in the resistance of the vessel. So that is high yield point. Okay, total resistance of vessels in series and in the parallel, so total resistant vessel in parallel. So what's the difference between series and parallel? So series are, if you look here, RT, which is resistant total, equals the R1, the R2, the R3. This is basically uh, your let's say aorta. Let's say this is aorta, or this is an artery. Let's just talk about this way. So you have a total, well, let's say one artery. The one artery is here. The second one is your arterioles. The third is going to be your capillaries, and so on. And the total pressure is just decreasing as you are moving on. It doesn't have an equal pressure, right? So in the other one, in the parallel now, the difference in parallel is that all of them have equal pressure. As for example, the example here is this is aorta, and it just branches out. For example, celiac artery, SMA, IMA, all of that, right? Okay, give me 1 second. Okay, so we were talking about this, how the parallel are from R1, R2, and R3. And the important thing, the whole thing about all of this is that the resistance in the series, as you go down the line, you're just decreasing the resistance, because this right now R1 has the most resistance, goes down, goes on. But in the parallel, everything is same. In the other words, the blood that is going here, eventually you're decreasing the resistance with the R3. But here in the aorta, you have equal resistance in each one of them, because it's equal amount of blood going in all R1, R2, R3s. So just read a little bit from here. Uh, and one more thing is not only resistance, but also the blood flow. So in the series, with each blood vessel receive the same total blood flow with the series. But with the parallel, each artery receive a fraction of total blood flow. So here, so let's actually do this. What about the resistance? So blood flow and resistance in these two things. So the blood flow in series is same, while the blood flow in your parallel, they only receive fraction. So receives fraction of total blood flow, total blood flow. While the resistance, on the other hand, in series, as the blood flow, the pressure decreases. So pressure decreases as you move on and on from R1 to R2 to R3. While in the parallel, with each parallel artery, the pressure is same. Pressure remains the same. That's important, and this is also important. So two things are there, and that's all about your resistance and blood flow. But here we have Q, which is the volumetric flow rate right here, is directly proportional to your resistance to the power 4. While the resistance itself, my bad, it's a radius to the power 4, while resistance is proportional to 1 by radius 4. So capillary, all you have to know is the radius is to the 4. So if you were to change in the radius, there's a large change in resistance. Radius, so here, let's just do this actually. This is a high yield point, so let's look more detail in it. So look in here, let's just draw it here. R, which is radius, you see it's by R4, right? So radius is indirectly, which is mentioned right here, I'm just writing it down. It is indirectly proportional to your R4. So resistance is indirectly proportional to radius. So if you increase your radius, you are going to, if you increase the radius, you are going to decrease the resistance. And if you decrease the radius, you're going to increase the resistance. And what is increasing radius means? Basically more dilation of the vessel versus more constriction of the vessel. So it is just gotta know this. It is indirectly proportional to each other. Okay. Now the next thing is that you have the pressure gradient drives flow from high pressure to low pressure, high yield. The pressure gradient would drive the flow from the high pressure to the lower pressure. Okay, arterioles account for most TPR, and we talked about it how arterioles have the highest resistance, so they account for the most total peripheral resistance. The veins provide the most of blood storage capacity. So veins are capacitant vessels, while arterioles are resistant vessels. Okay, viscosity depends upon hematocrit. Hematocrit viscosity would increase, meaning hematocrit would increase in not hematocrit, but viscosity, meaning how viscous a fluid is. That would increase if you have increase in hyperproteinemic state, for example, multiple myeloma, polycythemia, right? Viscosity would increase as you increase the things that are in blood, you increase them to an abnormal level. It's going to increase the viscosity, meaning the blood is going to be very, very thick, right? The viscosity would decrease with anemia, right? And that's there. So yeah, this is all we have for this. Just to review it, the whole thing, all you gotta know is one high yield point resistance is irreversibly proportional to the radius for high yield. Arterioles, they account for the TPR. Veins account for the capacity of the storage capacity, the capacitance vessels, right? And that's pretty much all. Moving on with the cardiac and vascular function curves. So here, what do we have? It's, if you look here on the left side, we have the cardiac output, we have the venous return, and on the other hand, we have, on the x-axis, we have RAP. What is RAP? Right atrial pressure. Right atrial pressure. This is x-axis. And that is going to be your y-axis. Okay, so looking at this graph A, okay, one more thing actually. Intersection of the curve, which is right here, this point, equals the operating point of heart, okay, which is i.e. venous return and the cardiac output are equal as the circulatory system is a closed system, right? So at this point, for example, you can say all the circulatory the whole thing, there is no coming in, the fluids are equal. Okay, so let's look at how in the first A picture what is going on there. So let's change color. Look in the picture A, inotropy. What is inotropy, right? Inotropy is about contractility. It is the changes in the contractility which causes altered stroke volume, which leads to altered cardiac output, VR, or venous return, and right atrial pressure. So what are we're trying to say? A simple thing. This was the normal point, right? We were looking at normal. So they're saying if you increase the contractility, inotropy, which is again same thing as contractility. You increase the inotropy or increase the contractility, you will alter the stroke volume, and you will lead to. So look what's going to happen here. You from this point, which was right here. Okay, my bad. Let's just do this. This was normal. So you moved from this point to this one. You increase the cardiac output. You increase the venous return just by increasing the inotropy, which is your contractility. But on the other hand, if you decrease the contractility, decrease the inotropy, you would decrease the cardiac output and the venous return. Simple thing, right? So let's read. what would increase and what would decrease. In point 1, they're saying, let's look at point 1 right here. Catecholamines would increase. The inotropy would increase the cardiac output and the venous return. Dobutamine, milrinone, digoxin, exercise. So anything that is increasing the contraction on the heart will cause increase in cardiac output and increase in venous return, because the more the fluid goes, it's a closed system as we mentioned here, so the more goes out of the heart, the more comes back in, which is venous return, right? Simple thing. But if you look at the point 2, what are they trying to say there? They're saying what would decrease the inotropy? To decrease inotropy, you have a heart failure with reduced ejection fraction, narcotic overdose, or sympathetic inhibition. So heart failure, heart is fail. I mean, no matter what you do, heart is failing. You're not gonna get your heart to pump more fluid out or blood out because it's failing. So for sure, you would decrease inotropy. There will be no contraction or not much contraction. With narcotic overdose, and they are slowing down the contraction of the heart. Sympathetic inhibition, they would inhibit these catecholamines, working on the receptor and causing a decrease in contractility. So these are just the factors. Somehow, I think understanding is way better than memorizing. If you understand it, what is inotropy? Inotropy is contractility, and whatever would increase the contractility would increase the cardiac output, because contraction, as you contract, you increase cardiac output. What is cardiac output? Whatever comes out of the heart, and as you increase the cardiac output, you would increase the venous return, because it's a closed. We have a closed system. We don't have anything that goes out of from our system. Whatever it goes out in the aorta, into the veins, venules, arteries, capillaries, go back into the venous return and come back as a preload. So it's a closed system. In simple terminology, increasing contractility, all these factors, decreasing in contract, all these factors. Moving on with the next graph, what do we have? So next graph is for, let's change color to, okay, so graph B, so it's about venous return. Venous return, what do we have here? So in venous return, so changes in circulatory volume would cause altered RAP, which was your right atrial pressure, which altered the stroke volume, and which lead to change in cardiac output. So in the first inotropy, we're looking at this graph, right? Like up and down. Now we're looking at the venous vascular function curve, this one. So what would increase or decrease vascular function curve, which would mess up the mean systemic pressure? Either it's going to increase the mean systemic pressure or decrease the mean systemic pressure, or another way, it's going to decrease the RAP, which is right arterial pressure, or increase the right arterial pressure, right? So what are the things that would change the venous return? Okay, let's look at it. So the first thing that would increase the venous return would fluid infusion. You give more fluid, you would have increased venous return. No rocket science about it. Sympathetic activity. You constrict the vessels, the more venous return you're going to have. AV shunting. The more from the AV shunts, meaning from atriovenous shunting occurs, the more venous return you're going to have, because it doesn't have to go through all that system of artery, the vein, the capillary, the venules, and the veins, right? It's going to go straight from artery to vein, straight up. And that would increase the venous return for sure. Acute hemorrhage. And now the other one is, how would you decrease the venous return? If you lose blood, acute hemorrhage, or you're giving spinal anesthesia would inhibit it. Okay, so spinal anesthesia is sort of a new thing, or something that doesn't go into the mind much. So just think about spinal anesthesia, that would decrease the venous return, and to a point that you can think, okay, spinal anesthesia, you have venodilation, and the more blood is just staying within the extremities, not going back to the heart, is causing decrease in venous return. Okay, now the last one is all about your total peripheral resistance, TPR. Let's change color first. So TPR. So let's look at TPR. TPR is your total peripheral resistance. A change in total peripheral resistance will again alter the cardiac output and changes the rep. So first we were just looking at how inotropy, which was your contractility, would only change cardiac output or your venous return. Then we looked at venous return and we said, okay, venous return is only going to change your will only change your right atrial pressure, right? And now we're looking at all things together. We're saying, okay, changing the TPR would not only alter your cardiac output, venous return, but on top of that, it will change your right atrial pressure. Okay, so what is TPR? TPR again is, in a simplistic words, TPR is your total peripheral resistance. Whatever resistance you have in the peripheral arteries is going to give you TPR. You vasoconstrict the arteries, you will increase TPR. You vasodilate these arteries, you decrease the resistance or decrease in TPR. Okay, so looking here now, so vasopressors vasopressor stimulators would increase the TPR. How? Because look, let's look at this graph now. This was normal. You have increased the TPR. It has moved the curve towards a little downward shift. Why? Because now at this point you have messed up your cardiac output. You have decreased the cardiac output. At this point you had a higher cardiac output, but as soon as you have increase in TPR, you are going to it's going to be hard for the heart to push out into the closed or vasoconstricted vessels, so the cardiac output from the heart here is going to decrease. So cardiac output decreases when you increase TPR. Vice versa, when you decrease TPR, the cardiac output increases. Okay, and what is the sixth one? Exercise. Exercise would decrease the TPR and AV shunts. So remember we talked about AV shunt. Okay, AV shunt, and I think they have mentioned at the bottom, and we'll see how that is working. So change often occurs in tandem, maybe reinforcing. Example, exercise would increase inotropy and decrease TPR to maintain cardiac output, or compensatory heart failure decreases inotropy, fluid retention, increase preload, maintain cardiac output. Okay, so yeah, that's what we have. But one extra thing that we want to look at is, let's just write it here. That is, so in order to maintain blood, let's just write it here. Okay, in order to maintain the blood flow through the blood, blood flow in the pulmonary circulation must match. So whatever goes into the pulmonary circulation, it must match the blood flow in the systemic circulation. In exercise and at rest, because it's a continuous closed circuit, with the exception of bronchial circuit. What is bronchial circuit? In which the systemic circulation will give you systemic circulation gives off a branch to the bronchial artery, which supplies O2 and nutrition to the lung parenchyma, and then drains deoxygenated blood to left atrium straight up, making right to left shunt. And this accounts for less than 5% of total cardiac output. So what do I mean by all of this? So all this is a very high yield point, which is it's saying that whatever blood flow that you have in your pulmonary circulation, which you think is very small, it must match it must match the systemic circulation, because we have a closed circuit here. Because it's mentioned right here, it's a closed system. It's a closed circuit, right? But there is an exception to this rule. What is the exception? Exception is bronchial circulation. What is bronchial circulation? Remember, the lungs. Let's just draw the lungs here. The lungs are so pulmonary artery goes into the lungs. The lungs give off pulmonary wind, which goes into your left atrium, right? But it's not supplying the blood to the lung tissue itself. So who is supplying the blood to the lung tissue itself? That is your bronchial circulation. So bronchial artery supplies the lung parenchyma, and bronchial artery has a oxygenated blood, and when it supplies the parenchyma to the lung, it becomes deoxygenated, and then it drains that deoxygenated blood straight into left atrium, and it is basically right to left shunt. That is why we will never have 100% O2 in the aorta or anywhere in the left atrium because of this shunting, which is normally happening. That's an important high yield point. The next high yield point is this point right here, mean systemic pressure. Mean systemic pressure. When venous return intersects the x-axis, which is right here, this point, it indicates the venous return of 0. VR, venous return equals 0. At this point, the all circulatory flow ceases, and the pressure throughout the circulatory system equalizes. This pressure is termed as mean systemic filling pressure, which is right here. Mean systemic filling pressure. So if somebody asks mean systemic pressure, you should know that mean systemic pressure is when the venous return equals 0. At what level? When the venous return. So if you look, let's say, actually, you would say, what is 0? So look, what is cardiac output? It is 0 at this point, right? What is RAP, right atrial pressure? It is 0 at this point. So that's exactly what I'm trying to say here. That at this point, at your mean systemic pressure, all circulatory flow ceases. All circulatory flow ceases, and there is no fluid going here or there, and the whole circulatory system equalizes in pressure, and that the whole thing is termed as mean systemic pressure. Okay, so that's all for this page. Moving on with the next one. Okay, we have a pressure volume loops and cardiac cycle. Okay, pressure volume loops and a cardiac cycle. So the black loop represents a normal cardiac physiology. So we can see here we have a aortic valve closure. It actually starts from here, which is a mitral valve opens and a mitral valve closes right here at this point. You just have pressure builds up to a point till the aortic valve opens, and then the fluid just goes out of the left ventricle, and to a point when it just expels out the whole fluid, the blood, and then the aortic valve closes and the pressure decreases, and again filling starts. So let's read this now. So we have the phases of the left ventricle. The first one, which is isovolumetric contraction. Isovolumetric contraction, which is the period between the mitral valve closure and mitral valve closing and aortic valve opening, period of highest O2 consumption. So what does isovolumetric mean? Isovolumetric mean constant volume. Isovolumetric, constant volume. Okay, when no blood is ejected from the ventricle. So isovolumetric contraction basically means we have a volume which is same, which is isovolumetric, meaning constant volume, and the contraction mean the heart is still contracting to achieve a level in which you can have a systolic ejection, meaning you can eject that fluid out, right? So this is right here. Look at this point 1. So what is this point? Period between mitral valve closure and aortic valve opening. So this is the period. So from this point to this point is your isovolumetric contraction. Okay, so the next point is your systemic ejection. Systemic ejection is the period between aortic valve opening and closure and closing. So from this, so let's change color. This is point 2, which is point 2 here. So from here, from this point, when the aortic valve opens to this point, it is going to be your systolic ejection, which is period between aortic valve opening and closure. Okay, now what's the next one? The next one is about the isovolumetric relaxation. Again, isovolumetric meaning constant volume. Relaxation means the heart is just relaxing. It goes from aortic valve closure till the point that mitral valve opens. So period between aortic valve closure and mitral valve opening, right? And what's the next one? The next is this right here, which is rapid filling. What is rapid filling? Is the period just after the mitral valve opening. So fourth and fifth are together. So what is fifth? Reduced filling, meaning period just before mitral valve closure. So as you know, the right away when you open the mitral valve from this point, the blood is just going to rush into the left atrium. So when it rushes in, it's called rapid filling, and when it is filled enough, it becomes reduced filling. Simple, no rocket science about it, right? So from here to here is from mitral valve open till the mitral valve closure is going to be your rapid filling and reduced filling, or in other words, you can call this ventricular filling phase. Ventricle filling phase. Okay, so this is all normal, right? So now what we look at is how when you increase contractility, what's going to happen, and when you decrease contractility, what's going to happen. So let's look at the first one, when you increase the preload. So you increase preload, which is now, this is right here. So if you look at this green line, what is it? So normally we had this point, which is you're giving you left ventricular volume, right? Left ventricular volume, and this is your end diastolic volume, meaning whatever the fluid had to come into the left ventricle is there now. That's end diastolic volume. So when you increase the preload, increase preload would lead to increase in end diastolic volume, and it was shifted right here, that increase in diastolic volume, right? In other words, what you should write on the book is, this point is your preload. This point is the preload. This point is your afterload. This point is your contractility. And yes, that's all you need. So let's now try to understand it. So we have, let's actually zoom in. Okay, so we say when we increase the preload, which is right here at this point, right? Preload is this point. We increased it to this point. We increase the preload, that would increase the stroke volume. So that is increasing the stroke volume, right? And when we increase the afterload, which is this point right here, look at this graph now. We're just increasing the afterload, right? So that is going to increase the aortic pressure, That is going to decrease the stroke volume. That is going to increase the end systolic volume. Look, this is increasing the end systolic volume, one thing. It is increasing the aortic pressure, and it is decreasing the stroke volume. Right. Just by increasing the afterload. But just know the graph. So when you have a graph like this, which is a pretty different graph than normal, this is when you increase the afterload. So when you make it more like bigger, increase this preload and increase in EDV, you are just increasing the preload. Now the only one thing is left is the contractility. When you increase the contractility, which is your brown graph, which goes from here, from this point to this point, you're increasing the contractility, right? That is going to increase your stroke volume, increase in ejection fraction, decrease in end systolic volume. For sure, it decreases end systolic volume, and systolic volume decreases. For sure, it increases stroke volume and increase in ejection fraction, EF. What is stroke volume now? Most ideal point. Stroke volume is this line right here. So the bigger you have, let's say it's a D shape. In other words, that's a D shape, let's say. The bigger you have the D shape, the more stroke volume you have. Why? Because that would tell us that you have more end systolic volume that has to be pumped out. And again, if you look at stroke volume is end diastolic volume minus end systolic volume. The more you have this, the more you're going to pump out, and the bigger the curve would be. But just to remember, this is the stroke volume. So as the curve goes higher, as this thing goes bigger, you increase the stroke volume, right? So let me give you an example. For example, in this one, in contractility, this is the brown graph. This is the brown graph. Look at the brown graph. What's happening to your stroke volume? It is increasing. So increase in stroke volume. And you already know when you increase stroke volume, ejection fraction is going to increase. Now look at the preload. Preload, the graph is green. Green starts from here, goes towards all the way here. You have increased this stroke volume because of you increased in preload. But if you look at afterload has a decreased stroke volume. So let's just look. This is the blue curve. So if you look here, from blue to blue, it's a very less than normal. Normal is all black, right? Less than normal stroke volume. So afterload is in afterload, the stroke volume is decreased. Okay, so that's what we have. As for a mnemonic, you have mnemonic MAM Coco. What is MAM Coco? Well, MAM Coco is, so first 1, 2, 3, 4. So this is 1. Mitral closure, aortic open. Aortic closure, mitral open. MAM Coco. So okay, mitral closure. Okay, how about this? Let's just do it one more time in a better way. MAAM Coco. So let's look at the first one. Mitral closure, MC, mitral closure, that's 1, 2, 3, 4, right? 2, aortic opens. Third, and this is from you will not my made mnemonic. Aortic closure is this, and MO is again mitral open is the 4th point. So in order to memorize a graph, like where the walls are closing and starting up and closing, MAM Coco could be a mnemonic that you can utilize. Okay. Okay, one more point. Let's erase all of this now. And let's talk about one more point here, which is also important. When this aortic valve opens right here, this site, what's going to happen is that you have, this is systole, right? So aortic valve opens when the left ventricular pressure is greater than the aortic pressure. So in the left ventricular, so pressure is increasing to a level when the ventricular pressure is going to be more than the aortic pressure, and snap the aortic valve opens, AVO, aortic valve would open right away. And this is called systole, and it would go into systole. Okay, and this closure of the aortic valve, let's talk about this one now. So aortic valve would close at the end of isovolumetric contraction when the left ventricular continues increases the forward blood flow to aorta, causes decrease in, okay, so when the left atrial pressure decreases, then the aortic pressure, the aortic valve will close, and this is the diastole. So systole is all this area, and after closure this is going to be your diastole. So maybe I can just draw them in a better way. Here's what we have. So we are saying this is systole. This all is systole. And changing color, this all is going to be diastole. Till this point, it's going to be diastole. Why? Because there is no contraction. So systole, you have to add this point as well, because there is contraction starts from this point. Okay, so that's what you have. That's all for this pressure volume loop cardiac cycle. Moving on with this next one, which is the heart sound. What is heart sound? We have S1, S2, S3, S4. S1 is basically you have mitral and tricuspid valve closure, which is loudest at the mitral area. That's the S1. So let's just actually draw it. That will be better. So if you recall, so you have a right atrium and you have a right ventricle. You have left atrium, you have left ventricle, right? So between these two, you have a tricuspid valve and a mitral valve. Meaning from right atrium to right ventricle, you can have a tricuspid, and from left atrium to left ventricle, you can have mitral. So and between these two, meaning when you take out the fluid from right ventricle, you're going into the pulmonic valve, and when you take out the fluid from left ventricle, let's actually do this. Wait, it's a better way. Right atrium, right ventricle. Right atrium. Actually, do it. Right atrium has which valve? It has a tricuspid valve. Right ventricle has which valve? It has a pulmonic valve. So left atrium has which valve? Mitral valve. While you have left ventricle, which sends the blood into aortic valve. Right? Change the color. Now what were we looking at? So what is S1? S1 is when the tricuspid and the mitral valve close, because this is all atria. Remember, this is all atria, and this is all ventricle, and the endocardial cushions are the ones which are dividing them, right? So this guy is going to contract at one time, and this ventricle is going to contract at one time, right and left ventricle. So when the atria contracts, it's going to give you S1. When the ventricles contract, it's going to give you S2. And which valves are we specifically talking about? Tricuspid and mitral gives you S1. Pulmonic, aortic gives you S2. So let's now read the book. What do we have? So S1 is the mitral tricuspid valve closure, as I mentioned. Is it loudest at the mitral area? S2 is aortic and pulmonic valve closure, loudest at the left upper sternal border, right? So this is the way I have it over there. It's a very easy way to understand that. Now, what is S3 and S4 now? So S3 is going to give you It's an early diastole during rapid ventricular filling phase. So again, it's coming in early diastole rapid ventricular filling phase. Best heard at the apex with the patient on the left lateral decubitus position, associated with high yield at this point. What is it associated with? It is associated with increase in filling pressure, for example, in your MR, mitral rigor, for example, in aortic rigor, in heart failure, and thyrotoxicosis, and more common in dilated ventricles. More common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. High yield again. So pathological factors and physiological factors are young children, athlete, pregnancy, high yield points. S3 is found in pathology, which pathology? MR, AR, HF, thyrotoxicosis. And in physiologically, you're looking at young adults, athlete, pregnancy. Turbulence caused by blood from left atrial mixing with increase in and systolic volume. Okay, so S3 is, let's highlight points here. S3 is an early diastole. It is due to the fact in these pathologies or in these physiological factors. S4, if S3 was early, again, as the name suggests, S3 is early, so S4 is going to be late, right? So simple. It's the late. Let's change color. It is going to be, S4 is going to be late diastole, which is known as atrial kick, right? And why would the atria kick? Because you have stiffed left ventricle. So atria is going to kick the blood out, push the blood out, contract it out, due to the fact that you have stiffed left ventricle, and that stiffness, that when you're pushing against some resistance, some stiffness, there's going to be a sound that is produced. That sound is S4, which is going to be seen in late diastole. It is best heard at the apex. Again, this guy was also an apex. This is also an apex, where the patient left lateral decubitus position, and with the patient with the left lateral decubitus same position. Okay. High arterial pressure associated with venous non-compliance. So what is this guy associated with? Hypertrophies. Considered abnormal if palpable, and it is physiologically present in older adults. So pathologically in hypertrophy and physiologically in just the older adults. That's the S4. Now, the question is, which hypertrophy are we looking at? So there are two different hypertrophies. That's high yield. So this hypertrophy is basically due to the fact that you have a concentric hypertrophy, and we will talk about what concentric and eccentric hypertrophies are in other lectures. But this is concentric hypertrophy, just to remember in the mind. And while the other one is going to be your eccentric hypertrophy. So if you look here, they're saying dilated ventricles. So what do they mean? They're trying to say eccentric hypertrophy. Okay, and that is going to be all for S3 and S4. Okay, now looking at JVP, jugular venous pressure. What do we have? So JVP, let's change color. JVP, jugular venous pressure. So JVP, if you look here, you have an A, C, X, V, and Y, right? So now, whatever is going down is going to be the descent. Whatever goes down is the descent of that. So look at the A wave. A wave is going up. So we call A wave an atrial contraction occurring at that time. So atria is contracting. That's going to be A wave. It is prominent in AV dissociation, canon A wave, absent in the mitral fibrillation. But what is A wave? That's important, which is your atrial contraction. A for atria. Atria contracts, makes a positive pressure. The curve goes up, and that's the A wave. C wave, on the other hand, is the right ventricle. So just imagine the whole thing in your head, right? So now when the atria is contracting, of course the blood is going into the right ventricle, right? So atria is contracting into the right ventricle. Yeah. So now the right ventricle is the C wave, because now this right ventricle is going to contract the blood out. So right ventricle would contract, and that would give you the C wave. Now the descents are always the things that are going down, like um, on this the graph is descending. It's simple descent. So there are only two descents: x descent, y descent, right? So what is an x descent? Well, x descent is, so first thing was atria contracted, the blood came into the right ventricle. Right ventricle contracted, the blood went into the pulmonary circulation. Now the cycle has to continue, right? So now this guy has to relax. I mean, it contracted. Now it has to relax. So X descent is the atrial relaxation, and downward displacement of the tricuspid valve during rapid ventricular ejection phase, reduced or absent in tricuspid regurg and right heart failure, absent because gradient are reduced. Important thing is atrial relaxation, and these are the factors which could cause atrial relaxation, or it will be absent in these diseases. But what is X descent, which is relaxation? V wave is simple. Is the now when we relax the right atrium, this thing we have relaxed it. Now there is an increase in right atrial pressure, because increased volume is coming in from superior inferior vena cava, right? So the volume is coming in because we have now relaxed it. Then the volume comes in. It again goes if you look here, the pressure is building up. It's now called the V wave. From here to here, right, is the V wave. So V wave, simple thing, pressure coming up, causing increase in right atrial pressure. Now the last thing is the Y descent here. Y descent is your right atrial emptying into the right ventricle, prominent in constrictive pericarditis, absent in the cardiac tamponade. What is Y descent? Again, the cycle, as I said, the cycle is continuing, right? So right atria is it is emptying into right ventricle, but not to a point that it has to contract. It's just, you can say, just open up the valve and the fluid is just going into the left ventricle, because when it contracts, it is going to give you an A wave. When it just opens up and the right atrium is just pushing not even pushing, it's just the fluid is just going into the right ventricle, that is going to be your Y wave. So A and Y wave are sort of, if you look at it, again, they're looking at one thing is atrial contraction in the A wave, and Y wave is looking at the emptying of the right atrium without any force. Because as soon as you apply the force, that's going to be A wave. So let's recall the whole thing and move on with the next one. What do we have? Okay, JVPs. JVP, we have two descents, X and Y descent. Just know that there are two descents, X and Y descent. All the other are just the waves. So we have the A wave, which is atrial contraction. Atria contracts the blood into the right ventricle. That's going to give you A wave. Now there's a C wave. What is a C wave? C wave is when you have right ventricle has to contract the blood out from the right ventricle into the pulmonary circulation. So that's going to give you C wave. So AC. After AC, you have a descent. What is that descent? That's the right atrial relaxation. X for relaxation, right? Right atrial relaxation. After the relaxation, and now the right atria has relaxed. Now there's a V wave, that there's just going to be fluid coming from the superior vena cava, inferior vena cava, increasing the right atrial pressure. That increase in pressure will give us V wave. After the V wave, you have the last one, which is your Y descent, which is again the same thing as the first one, except that there is no contraction, in which case you have just the right atrium will be emptying into the right ventricle without a force, because as soon as you apply force, you're going to go back into A wave. And that's all JVP.